I'm Professor Mike Kirby. I work at the Prostate Centre and the University of Hertfordshire. And I'm going to discuss erectile dysfunction after radical treatments for prostate cancer. This has been prompted by a survey which was commissioned by Prostate Cancer UK a few years ago. We're just about to publish the results, having put the data together. The disappointing thing is that many men, in fact, if you ask them, get very little advice or support with the sexual consequences of radical treatment for prostate cancer, whether it be surgery or radiotherapy. And of course, the problems are compounded in those men who get androgen deprivation therapy. GPs, on the whole, say they have insufficient education and knowledge about managing erectile dysfunction after pelvic cancers. Urologists do considerably better when it comes to asking the question and dealing with the problem. Patients undergoing radiotherapy seem to get very little advice about the sexual complications of radiotherapy or how to deal with it. The whole situation is compounded by the fact there's a lack of good evidence base about how to actually manage this problem in an optimal manner. We've produced guidelines published 2 or 3 years ago for the UK with particular regard to surgical treatment and radiotherapy. But the GPs seem to be unaware of these guidelines. We do need to remember that GPs get 200 guidelines a year, so it's hardly surprising. The key thing is that after radical treatments, you get apoptosis occurring in the penis, you get a reversal of the smooth muscle to connected tissue, and if the men aren't supported with PD-5 inhibitors, vacuum devices, intracorporeal injections, then by the time the nerves have recovered, either from surgery or radiotherapy, then the erectile tissues simply will not work. The key thing is that although there's a lack of evidence base, doing nothing is really not an option for these men because of the impact on quality of life. Ideally, PD-5 inhibitors should be started on a daily basis, probably before the operation or before the radiotherapy, continued for many months afterwards. If erections fail to reappear, the men should be offered a vacuum device which can be used as a form of penile therapy or intracorporeal injections. Topical treatment intraurethral with Muse or Vitaros is also particularly helpful. At the end of the day, after 3 or 4 years, penile implant is also a good option for these patients, but often doesn't get discussed or recommended. So the key message from today is, please ask the question. If it's troubling the man, then something must be done, starting with PD-5 inhibitors, vacuum devices, intracorporeal injections, with an optimistic view that if you can keep the erections going, they may often return in the long term. Thank you.